My dear esteemed faculties, my dear lauded audience, Assalamu alaikum and very, very good morning. So today my topic, side roads are not always pleasant. So I'm talking about iatrogenic coronary artery dissection. So iatrogenic coronary artery dissection is infrequent but catastrophic complication. So incidence is less than 0.1%. Prompt recognition and management is crucial. Important factor determining the prognosis, size of the compromised vessel, integrity of the anterograde flow. And we can identify the dissection by subtotal or total lumen occlusion. Patient may complain of severe chest pain, nausea, vomiting, slowing down of heart rate and blood pressure. ST segment elevation in culprit vessel related leads or severe arrhythmia, but it might remain asymptomatic. There are some factors, patient factors and the hardware manipulation. So patient factors are calcification of the osteoproximal part or any part of the coronaries, then atherosclerotic plaque, vulnerable ones, anatomical distortion of aortic root or origin of coronaries. And about the hardwares, the angle might formed by the tip of the catheter and the intima of the vessel might be not coaxial. The depth, it might gone inside the arteries. Then forceful injection with dampened pressure and may be due to mismatched balloon catheter or stent with arterial lumen. So this is the classifications of dissection. National Heart, Lung and Blood Institute, they have classified the dissection type A, B, C, D, E, F, and A and B are said to be not non-lethal, but the C, D, E, F, they have high mortality and morbidity. Dissection consequences depends on severity of the coronary flow obstruction or location of the dissection. Stenting of the dissected vessel, be very careful. Stenting of dissected vessel is not the same as stenting of non-dissected vessel. So higher rates of complications like propagations of the intramural hematoma will expand the dissection and later stent malapposition due to hematoma reabsorption. So let's see a couple of cases. First case, a 55-year male, recurrent chest pain on minimal exhaustion for 2 months, his ETT was positive. So there is a significant stenosis in the mid RCA. Can I have a pointer? And there was stenosis in the LCX, distal LCX. Can I pointer? So we pre-dilate the lesion and stent is deployed, but during the placement of the stent, we can see there is a dissection in the osteoproximal part. It might be due to guide induced. So we stented the vessel and then another stent and the dissection, I think the linear ones, and we placed a stent. And this is the final result, from osteal RCA to the previous stent, overlapping with the previous one. Another case, a 52-year male with recurrent chest pain, positive ETT. He has got osteoproximal LED lesion involved in the distal LM. RCA was normal. Then we wear both the LED and LCX and pre-dilatation done. After that, there was a dissection of the LM. So promptly, and patient developed chest pain, hemodynamically unstable, and then we promptly placed a stent and deployed from LM to LED. But unfortunately, the dissection extended to the LCX. So we did port 4 balloon, then this LCX was stented and FKBI done, and this is the final scening. After that, we did the IVUS. It shows the stent was well opposed and the luminal with good luminal area gain. Then another case, female patient with chest pain, ETT was positive. The left system was normal, but RCA engaged and the dye injected. It's like a black wave of dye moved from proximal to the distal part. Patient developed chest pain and become hemodynamically unstable. So there is, you can see the distal portion was occluded, totally occluded PDA and PLV. So you can see the dye held, occluding the PDA PLV, and patient was hemodynamically unstable. She developed complete heart block, and then the TPM was done, and then we took the guide, and then thought that we managed to wear the RCA, and we tried to stent the proximal dissection point. So after that, there is no distal flow. So we thought whether we are in a false lumen or not. Again, we tried to pass another wire. It also goes to supposed to go to the distal lumen. Then we stent the proximal part and also the distal part, covering the dissection. Still, there was no flow in the PDA. So we again manipulate the wire, tried to manipulate the wire through the PDA, though there was a dissection, but there was distal flow was satisfactory. Another tortuous lesion in the proximal part. So left system was normal, pre-dilated with 2×12 balloon. After that, there was a osteoproximal dissection. So we put a long stent from ostial RCA, and this is the final cine. Another case, there was a RCA lesion, mid RCA. So we ballooning and stenting done. After that, in stent boost, we can see the lower part of the stent is not inflated properly. So we took a post-dilated balloon, and after that, we found that there is a distal dissection. It is like type E dissection. So we stented the distal part, and this is the final cine. Another 75-year male with CSA, there was huge calcified lesion, rota done. After rota, we did the IVUS, and there was a dissection in the midpoint. So we checked with the dye and the distal vessel was occluded. So we aggressively dilated with scoring balloon, NC balloons, and distal part deployed distal stent and proximal stent. So there was stent migration. That is a different story. We won't go through that, but finally we managed to come out, bail out. Another patient, RCA was hooked, but I think it was not engaged in coaxial. There was a dissection in the proximal part, and then we stented it and bailed out. Another patient started with the wire passed through the false lumen. After that, the whole LED was blocked and totally occluded LED. Patient developed chest pain and hemodynamically unstable. So we managed to cross with the wire distally, and then we put distal stent and then proximal stent, and then a stent was placed covering the LM ostium. So this is the final cine. So we bail out like that. Another with retrograde, I think retrograde CTOs, but the RCA was dissected. You can see in the OCT. So prevention is better than cure. So what we should do not inject the damped pressure. The guide wear should be coaxial. Gentle wearing should be done. Avoid or oversizing balloon or high inflation pressure. Prepare a calcification well. So wearing a dissected vessel, we can do parallel attracting straw technique, and this is the algorithm for iatrogenic coronary dissection management protocol. So minor dissection may not require treatment. Long dissections in more than 50% stenosis, impaired TIMI flow, and a vessel more than 2.5 millimeters should be treated. LM dissection is fatal complication. It requires prompt treatment with stenting. Integral and management is obtaining and maintaining the wear excess. Crossing and recrossing the dissected segment can be done with a soft workhorse guide wear. Therapeutic strategies is immediate bailout stenting or emergency coronary artery bypass grafting. In case of LM dissection, bifurcation stenting strategy can be adopted. IVAS OCT can visualize the dissection entry point, dissection length, vessel diameter, and presence of the wear in the true lumen. And if antegrade variant cannot be accomplished, retrograde crossing, subantiminal reentry like stingray should be taken. Although limited data, typical approach to stent from dissection entry to an area of the normal vessel. So take home message, operator has to recognize the complication. Don't panic and be calm if complication happen. Seek help from your colleagues, interventionists, and as well as the surgical colleagues. Minimize contrast injection, disengage or non-selective shots should be taken, and try not to lose the wear if it is in the true lumen, and use longer stents but do not oversize to seal the entry point. Above all, the patient safety comes first. So your last mistake is your best teacher. সবাইকে স্বাধীনতা 26শে মার্চ মহান স্বাধীনতা দিবসের শুভেচ্ছা, and thank you all.